You're all welcome to this YouTube channel once again. If you're just joining us for the first time, please kindly subscribe and also don't forget to click the notification bell so you get notified each time a video drops on this page. We'll be looking at the surface anatomy of the thorax. Let's get right into it. Looking at the thorax, we'll first of all be looking at the anterior chest wall. The chest extends from the clavicles above to the inferior costal margin below, and it is formed of the ribs and costal cartilages. The sternum and associated muscles, the two sides of the chest, are usually symmetrical. Also, the rate, depth and character of respiration can be observed, as can the apex beats of the heart on the left side. The midline sternum is made up of the manubrium, the body, and the xiphisternum from above downwards. The suprasternal notch on the superior aspect of the manubrium is palpable. The manubrium and body are also palpable throughout their length, and they are united by a secondary cartilaginous joint forming the sternal angle, which is also called the angle of Lewis. The angle is at the level of the lower border of the fourth thoracic vertebral body. It forms an important landmark for the description of structures inside the chest. Ribs are counted from this site as it is consistently palpable. We have the second costal cartilage articulates on each side of the manubriosternal joint. Then in a teen male subject, many ribs are visible, but they may be obscured by overlying muscle, fat, or breast tissue. These structures can also make it difficult to count ribs by palpation. The first rib is not easily palpated, being deep to the fibers of the pectoralis major muscle and the clavicle. The second is consistently palpable at its cartilaginous articulation with the manubriosternal junction. The upper seven, which are the true ribs, they articulate directly with the sternum via their costal cartilages, whereas the 8th to 10th ribs, they articulate via the costal cartilages with the cartilage of the rib above. The clavicle is palpable throughout its length. It articulates medially at the sternoclavicular joint, like the temporomandibular joint. It has a fibrocartilaginous covering of its articular surfaces and contains a fibrocartilaginous disc. The pectoralis major muscle is attached medially to the clavicle and upper 5 to 7 costal cartilages. They are related half of the sternum and from the sheath of the rectus abdominis. Its fibers pass laterally to the lateral lip of the bicipital groove of the humerus and from the bulk of the anterior axillary fold. The pectoralis minor muscle is overlapped by the pectoralis major, and its tendon may be palpable high in the anterior axillary wall as it passes to the coracoid process. The coracoid process can be felt by deep palpation 1 cm below the clavicle under the medial anterior fibers of the deltoid muscle. Now, the lower 3, cervical, and all the thoracic vertebral spines are palpable in the midline. The spine and acromion of the scapula are subcutaneous, and its upper, lower, and medial angles can be observed and palpated during arm movements. In the anatomical position, the scapula overlies the 2nd to 7th ribs on the posterolateral aspects of the chest wall. Laterally, it articulates with the clavicle and humerus, but has no medial bony attachment, being free to move over the chest wall in movements of the upper limb. Much of the rib cage is impalpable posteriorly, being covered by powerful erector spinae muscles along the midline and the scapula, and its muscle attachments more laterally. The 11th and 12th ribs articulate with their respective vertebrae but are free laterally, and these ends can be palpated and this mobility confirmed. The trapezius and the latissimus dorsi muscles have attachment to the trunk. Their prime function is the movement of the shoulder girdle. The depth of the heart is usually in the left mid-clavicular line in the 5th intercostal space. The inferior border passes horizontally from this point across the midline, and the right border bulges slightly laterally along the right border of the sternum. Looking at the lateral chest wall, it is formed of the rib cage. This is bounded inferiorly by the costal margin and superiorly projects into the axilla. It is continuous with the anterior and posterior chest wall without any demarcating line. Ribs can usually be palpated along the length of this wall, but as the topmost rib felt in the axilla varies, counting is either from the floating ribs or by following a numbered rib from the sternum. The serratus anterior muscle is attached along the length of the anterior medial border of the scapula. Its fibers pass laterally and form 8 slabs. These slabs can be seen in a thin subject together with their interdigitations with the external oblique muscle on the middle 4 ribs. It is supplied by the long thoracic nerve from the brachial plexus. Now, looking at the female breast extends from the 2nd to the 7th ribs and from the lateral border of the sternum to the anterior axillary wall. It overlies the pectoralis major, the serratus anterior, and the external oblique muscles. The axillary tail of the breast extends superolaterally around the lower border of the pectoralis major muscle into the axilla. The size of the breast and level of the nipple are variable in the females. In the males, the nipple is in the mid-clavicular line over the 4th intercostal space. The axilla is a fat-filled pyramidal cavity separating the chest and arm. Its medial wall is formed by the upper 6 ribs, and the anterior and posterior walls converge laterally into the palpable upper shaft of the humerus. The anterior and posterior walls can be felt between finger and thumb. The anterior is higher and is formed mainly of the pectoralis major muscle. The posterior wall is mainly from the teres major muscle. The breast is palpated for abnormal masses with the flat of the hand compressing it against the chest wall. Its mobility over underlying muscle is assessed by subjects pressing their hands on their hips. Malignancy of the breast may spread to lymph nodes in the axilla, may also be involved in infection and malignancy at other sites. The nodes are sited in anterior, posterior, medial, lateral, and apical groups. The apical group is high in the axilla, communicating through the cervicoaxillary canal with the infraclavicular and supraclavicular nodes and lymph channels forming the subclavian lymph trunk. Normal axillary lymph nodes may be palpable, mainly as small nodules of 4 to 8 mm in diameter, often termed the shorty nose. Here we have it. This is the end of the lecture. Thank you for listening. Goodbye for now.